Good morning.
Good morning.
Just wait a few moments. Okay, I guess I see Maya and Molly, Tulsi and Tarek, and Sergey and David. We got the full complement. Okay, I guess we'll start by congratulating Mahmoud on fellowship. Congratulations. He'll be a cardiologist soon.
Thank you.
Good luck in Stanford. I'm sure you'll do great. So
Wow.
we look forward to your success,
Thank you.
which I'm sure will be substantial. Okay, so a couple of interesting tracings. All righty. So this is a tracing that Dr. Arnon was nice enough to share with me the other day. This is a 12-year-old who came in with vague complaints of palpitations and chest discomfort. So I'm going to throw this out to Maya. See what you think, Maya. What's going on here?
All right.
Can't hear you very well. Hello?
Can you hear me better now?
Much better. Thank you.
Okay, great. All right. So initially, I'm just going to kind of go through this system-wise. So I do see P waves before almost every QRS. There's a few QRSs that look different.
I
than the other
agree with
ones.
that statement. Yeah.
The P waves that I see are up in 1 and up in ABF.
Mhm.
So it does appear to be a sinus, or at least, there is a sinus atrial rate.
Mhm.
Um,
And what is the heart rate?
So the ventricular rate is, let's see,
Actually, I made an error. This is like a 4-year-old or a 3-year-old, let's say. Smaller
Okay.
child than I said.
So the ventricular rate is about, let's see, a little bit more than 100, like maybe 110 or so.
Okay.
However, about halfway through the tracing, we're seeing these QRS complexes that look a little bit different. They look wider.
Okay.
And
I think it's is it halfway through? I think the second beat is
there's
or the third beat.
there's actually that's maybe even the first one on the tracing. Yeah. So it looks like there is a ventricular bigeminy.
Well, bigeminy would denote it being after every other beat, right?
Yeah. I
Well,
guess
why don't
they're
you look
not
in the
full
rhythm.
by
I think the
time.
rhythm strip may be helpful to remember in this particular EKG machine and in our machines at Mount Sinai, the V1 lead on the bottom is simultaneous with the leads above. That, by the way, is not
Mhm.
true on all EKG machines, but in ours, they're simultaneous. So I think it's easier to assess the rhythm when you're looking at one lead, only because, with the QRS changing and every lead has a different morphology, it can be a little challenging sometimes.
Okay. So it starts to be every other beat about maybe 5 beats in. But initially there's, one of the wide QRS, and then there's 2 more narrow QRSs, and then it starts to be every other.
Is the rate regular or irregular?
Let's see.
It's hard on
It's
its computer screen. I realize this is,
yeah,
you can't really use calipers, so that you can feel free to take your calipers and put them to the screen.
it looks overall regular.
Yes, I agree. I
Yeah.
think this is regular. Now, normally when somebody is in bigeminy, which usually denotes a sinus beat followed by another type of beat, either a PAC or a PVC, the other beat is usually early, right? Because remember that when it comes to the rhythm of the heart, whatever is the fastest wins. And so if you are in sinus rhythm, that's why we're in sinus rhythm. It just happens that the sinus node has the highest degree of automaticity. And so we're in sinus rhythm. But when you have something, an automatic focus that is beating at a rate faster than the sinus node, we will be in that rhythm instead. And that's why when you're in, so let's just take it, for example, if you were in ventricular bigeminy, usually the PVC that follows the sinus beat would usually be early. So you would have a regularly irregular rhythm. Okay. But in this case, I agree with you, Maya, that the R to R interval is pretty much fixed. It's not those beats that look different than the others. And by those, I assume you're referring to this beat and this beat, this one, this and this. They are a different morphology than the other beats. Is there a P wave before each of those beats?
Yeah, there does look to be a P wave.
I agree. There does appear to be a P wave before each beat. So what would be an explanation for why the QRS is changing and is so much wider on those beats with a P wave in front of them?
So there could be like a pre-excitatory focus or a pathway. Looks like there could be a
Yes.
delta wave here.
Yep. So what do we call that when somebody is in sinus rhythm and sometimes conducts through their AV node, but sometimes conducts through their accessory pathway antegrade?
Like a Wolff-Parkinson White.
It is WPW, but normally, right, when someone's in WP has WPW, do they normally conduct back and forth between the sinus node, between the AV node and the pathway, or do they normally conduct through one or the other?
It's normally like one or the other.
Right. So what will we call this? Is there a term when you are intermittently going through one or the other?
Intermittent pre-excitation.
Yes, indeed. This is intermittent pre-excitation. So this is an unusual tracing, not unheard of, but certainly nice to see, of a patient who has intermittent ventricular pre-excitation. So can we infer anything regarding the risk for sudden cardiac death in somebody who has intermittent ventricular pre-excitation? And this is the reason why Dr. Arnon wanted to show it to me, because you don't see this every day.
I'm not sure, but I would guess that they would be at a higher risk.
Well, it was either higher or lower. Sadly, you got it the opposite.
Okay.
That's okay. So why do people die rarely when people have WPW? What do we believe is the mechanism by which patients, the rare patient who dies with WPW dies?
I guess they could go into a SVT that is somehow unstable or not perfusing well enough, then they could.
So interestingly, people don't die very often from SVT. I mean, there are rare cases of it. And actually, if you ever listen to my podcast about 6 months ago, I had Leo Lieberman on, and he wrote a paper in which he surmised that a bunch of patients who had SVT may have died from it. And I think I may have one patient who arrested who in retrospect may have just been SVT. But I'll never really know because there was no EKG on it. But generally speaking, we think SVT, by which we're referring to ORT, right, or AVNRT, generally is not life-threatening. It can be if you're like an infant and you've been in it for like 48 hours and you come into the hospital in low cardiac output syndrome and from being stuck in ORT for a really long time that was unrecognized, causing a cardiomyopathy. But generally speaking, people don't die from ORT or AV NRT. But what other arrhythmia are people with WPW at risk for? That's concerning.
Like a ventricular arrhythmia.
They do get a
attack.
ventricular arrhythmia, but how did they get a ventricular arrhythmia? What characteristic, when we're doing an EP study, we typically are testing the accessory pathway for its level of risk. How do we do that, and why do we do that?
Like when we like we put in beats at like shorter and shorter
Right.
R intervals.
Right. So we're doing it. You're referring to
lengths.
atrial extrastimulus testing. So we do that, and we can determine the refractory period of an accessory pathway, meaning how short can it conduct at. But what happens to people with WPW when they go into atrial fibrillation versus a otherwise healthy person?
They could have rapid conduction.
Right. So it's how fast the pathway can conduct antegrade that's really the whole ball of wax in regards to sudden cardiac death. So when we're doing atrial extrastimulus testing in a WPW patient, or when we're pacing the atrium rapidly, or when we frankly intentionally induce atrial fibrillation, what we are trying to do is determine what the antegrade refractory characteristics of the pathway are. How fast can it conduct? Because how fast is your atrium going typically when you're in atrial fibrillation, Maya?
It can be going pretty fast, like up to like 300 or so.
Right, could be 300 or even faster. Now, if you do not have WPW and you just have atrial fibrillation, how fast are their ventricular rates usually? What's a rough average range, let's say, for an adult? If I were to go into AFib today, what would be my ventricular rate roughly?
Usually just like a fraction, like 100, 150 or so.
Yeah, that's right. Now, why is that?
Because not every P wave would be conducted. So you can have,
right,
like,
because the AV node isn't like an infinite piece of wiring that can conduct rapidly at any rate, right? It has a refractory period of its own, and so the AV node basically protects the ventricle from going too fast. So yes, you might be able to go at 150 or 160 or 170. And so people who are in AFib generally don't feel well because their heart is beating rapidly, but they don't often acutely die because the AV node basically is almost like a stop sign. It doesn't allow that fast of a rate to go across. But what about accessory pathways?
So I guess might not have that refractory period. So
it can sometimes have a shorter refractory period. It can conduct at rates that are even faster than the AV node. And so we often say, we want to know at the beginning of an EP study of someone with WPW, do you have a high risk or a low risk WPW pathway for sudden death? And by that, we mean, how fast can it conduct? If one were to go into atrial fibrillation, would this particular patient be at risk for sudden death because the pathway can conduct very rapidly? So whereas a normal healthy person cannot conduct from A to V through their AV node much above 200 beats per minute, if you have WPW and if you have a pathway that is so-called high risk or slick, it can conduct very rapidly, sometimes as fast as 300 beats per minute. And so what was atrial fibrillation could become ventricular fibrillation, which is potentially life-threatening. So what do you think it means if when your heart rate is about 115 beats per minute, every other beat is pre-excited, or another way of saying it is every other beat is conducting through the AV node? in regards, what does it mean in regards to the refractory period of the accessory pathway, the WPW pathway?
So the refractory period might be longer than the R-to-R interval in this case.
Right. It means that the pathway may be wimpy, that it,
Mm.
you know, if it can't even conduct consistently at a rate of 115 beats per minute, then it might be that this is indirect evidence that this pathway is not high risk. So, and in fact, if you look at the formal recommendations of the American College of Cardiology and Heart Rhythm Society, and the AHA, they say that if you perform an exercise study and you lose pre-excitation suddenly as your sinus rate rises, that's good indirect evidence that probably you have a low risk pathway. And so this patient actually is intermittently pre-excited. So one could surmise that the pathway is not an especially robust pathway because it is intermittently pre-excited. Now, it turns out that actually that is not 100% true. There are cases of people who are intermittently pre-excited and do unfortunately have a fast conducting pathway. In this particular case, the pattern of the pre-excitation suggests that the pathway is left-sided. And sometimes in children, particularly, the AV node is so robust that it can conduct from the A to the V faster than it can go from the A to the V through the pathway because the AV node is physically closer to the sinus node. And so one may have intermittent pre-excitation, but the pathway actually can conduct well. It just appears to not be conducting well because the AV node is so robust in its conduction characteristics. And actually, there are a number of reports of rare patients who have intermittent pre-excitation and then have life-threatening events. So we can't hang our hat, unfortunately, on the presence of intermittent pre-excitation, but it is definitely a better sign to see than to see, consistent or persistent pre-excitation as the heart rate rises. So Dr. Arnon showed this to me as a sign, as just probably a patient who does not have a high-risk pathway. But we can't really say that definitively from this, but it is certainly reassuring. Do you have any questions about that, anybody? Okay. All righty.
That was very helpful.
Okay, let's move on to the next one.
So Dr. Paz, this patient does not need an EP study.
Well, that is a very good question, Sergey. So it really depends on your religion, I guess. In the present era, the formal recommendations of these different societies are that if you put this, I mean, we would expect that if you put this patient on a treadmill, that they would lose pre-excitation. I think we would probably at least recommend doing a stress test to see that you lose pre-excitation. And if you did, then the formal recommendations would suggest that it is not a high risk and that you don't have to do anything further in an asymptomatic patient. I'll tell you the truth that I think most electrophysiologists today are so worried about patients who non-invasively seem safe but are not, that I think it is slowly coming to the point where probably we're recommending that everybody be formally assessed in the cath lab. So at the very least, if you wanted to avoid the cath lab in a patient like this, I think we would definitely recommend the stress test, at least see that when the sinus rate gets even faster, that we have no pre-excitation. Sometimes you're quite surprised, particularly with left-sided pathways, when we see that the patient actually can conduct at faster rates. So this may, in other words, the intermittent pre-excitation may more reflect a very robust AV node than a pathway that can't conduct. Okay.
But sorry, one more question for this patient. You had said this kid is like 3 or 4, right? So I guess like in your decision making, because we're not going to likely stress test someone who like wouldn't be able to do it, I guess, like in terms of your discussion with family about that.
Right. So generally speaking, for small children, Although anyone can die from WPW at any age, generally speaking, most of the sudden death associated with WPW is in a slightly older age range. It's very unusual for a child this age to die suddenly with WPW. I don't want to say it's never happened. There are case reports of everything, but very, very rare. So as a general rule, in an asymptomatic patient with WPW, I personally would not restrict such a patient, and I would recommend consideration of stressing when the patient is old enough to easily have a stress test, which in most labs is roughly 8 years of age. You can do it younger. It depends on if you have a treadmill and you have a very mature kid. I've seen children stressed even at 4 or 5 years of age. But if you have a bike ergometer, as we use here, usually you have to be about 7 or 8 because you have to be tall enough to get your feet in the pedals and mature enough to cooperate with the study. But yeah, I would probably just do nothing. Now, some people would say, that you could take this. It also depends on your religion in regards to how early you think you should be doing elective ablations in children. Some electrophysiologists will argue that you can do patients as young as 4 or 5 years of age with a similar efficacy and safety to older. I don't personally agree with that, but I don't have a major disagreement. But I personally like to wait till patients are older, mostly because I feel like sometimes patients' pathways are harder or easier to ablate, and I would feel less comfortable in a small child using certain types of ablation tools, such as irrigation. I would generally not want to use that in a small child, but I might feel more comfortable if I had to in a bigger child. So you sort of like to have, shall we say, all the bullets in your armamentarium, and sometimes in small kids, you're a little bit limited. So now, if the child were very symptomatic, had lots of documented SVT, I think a stronger argument could be made. In this particular case, this pathway is left-sided. Generally speaking, the success rate and the safety of left-sided ablations is probably higher than in any other location. And so one might argue to proceed earlier in a patient with this pattern than in other patterns. But certainly for me personally, if I see a pattern that suggests an anteroseptal pathway location near to the AV node or a mid-septal pathway location, I will usually drag my feet until the patient is as big as possible in order to enhance the size of the heart and the distance between pathways and important structures like coronary arteries or the AV node.
Thank you.
Sure. Okay, so this is a tracing from a case I did many years ago, 3 jobs ago, and I am, in this case, performing a cryoablation. And, when one of the things I'll just mention, when we do a cryoablation, the cryocatheter creates tremendous artifact on the ECG. So that's why you can see what we've done here is we've clipped the electrical signal, because otherwise it just bleeds over the entire screen. You can't actually see what's going on. So when we cryoablate, we usually just do this. So we're cryoablating, and I guess the question is, can you tell from this tracing where the accessory pathway is and whether or not we were successful in this tracing at ablating this pathway? So I'm going to take this up to, why don't we ask Dr. Bebbia if you can tell from this tracing where, and just for the remember everybody, we have a couple of electrocardiogram tracings up top, high RA ablation, His distal to proximal, and CS proximal to distal with RV. So you can see I've been displaying it on the screen the same way now for over 20 years. So,
using the method that I used as a child when I was comparing 2 pictures, I can see that. So initially on the first few beats, when you look at the, I'm looking at high right atrial lead. So I kind of find the right atrial spike depolarization.
Uh-huh.
Then I go down into the to see how it conducts to the ventricles, and I can see that on the first 1, 2, 3 beats, I can see the earliest in coronary sinus, probably 5, 6, or well, it's more distal than proximal, which tells me that it probably the pathway is the left side pathway.
Mm-hmm.
And then on the last 2 beats, we see that actually this picture changes. So here, I guess the earliest is in the proximal, which tells us that this most likely is through the AV node. So I would say it's a left-sided pathway, and you were successful in ablating it.
That's very well done. So you were using the technique that we all learned in Sesame Street, which is, which of these is different from the others. So the first 3 are clearly different than the last 2. And so, yes, the AV interval, right, is very tight here. The earliest ventricular electrogram looks like it's probably in CS5-6. And then the AV interval widens significantly, and it's harder to tell on the surface because the paper speed is 100 millimeters per second, but we're going from pre-excited to not pre-excited. And actually, if you look in lead 2, notice how the QRS is down going, and then once we successfully ablate the pathway, it's now up going. So the QRS morphology changes quite substantially with ablation of the accessory pathway. Now, so very good, Sergey. So here's the question, though. Why would I be using cryoablation for a left-sided accessory pathway, do you think? Right, you've seen many ablations by me and Dr. Love, and I'm sure you've noticed that neither of us uses cryoablation for that. We rarely use it in general, but we certainly don't usually use it for left-sided pathways. Any thoughts on why I might have chosen to use a cryo in this case, as opposed to the more standard radiofrequency?
Well, I guess cryoablation is safer, meaning like you cause less permanent damage. So maybe this pathway was close to something that you didn't want to.
Okay. So are left-sided pathways usually close to anything particularly important? I mean, we normally ablate left-sided pathways with RF, right? So, I mean, the circumflex coronaries, right, is on the other side, but that doesn't seem to stop us from safely ablating pathways in that area. So, any other locations we might be on the left side where using RF might be more dangerous? So in this case,
I don't remember.
Yeah, so in this case, I don't remember the case, to be honest, but I can tell I have a good sense of why we probably use cryo. So we don't generally use cryo for left-sided pathways because, generally speaking, radiofrequency is very safe there. Now, I will make the caveat that there is a guy in Ohio who named John Clark, who has popularized the use of fluoroless ablation, and he uses exclusively intracardiac echo, or TE, plus just using 3D mapping, and doesn't use any fluoro at all. And he uses cryo for all of his ablations. And so he has described, putting multiple cryo applications on left-sided pathways with good success rates. But I think most electrophysiologists do not use that approach. In this case, my suspicion is that we were actually ablating this pathway from within the coronary sinus. And sometimes, as I'm sure you've seen, we are not able to get the coronary sinus catheter to go very far into the coronary sinus. And so my suspicion is that this pathway was probably located inside the CS, or not very far over on the left, even though 5-6 normally would be suggestive of a very lateral pathway, because we usually can get the CS catheter in pretty far. Probably we had tried to ablate it transeptally unsuccessfully, and then ablated from within the coronary sinus. Now, any thoughts, Sergey, on why we would not want to use radiofrequency within the coronary sinus?
Again, we don't want to damage something important.
Right. Well,
fragile.
So there is definitely higher risk when ablating within the coronary sinus. So the bottom line is you can perforate the heart, right? The coronary sinus is literally a vein. And so the way that radiofrequency works, or standard RF catheter works, is they are temperature controlled. And so the way that it works typically is when you're ablating in a structure. So when we're doing an ablation in the heart, we want to deliver with radiofrequency both radiofrequency power and temperature. The combination of power and temperature is what causes the destruction of the tissue. And the way a standard temperature control catheter works is that you tell the computer, I want the temperature to reach a maximum of whatever temperature you choose. In most cases, it's either 60 or 70 degrees Celsius. And then the catheter will generate whatever power is necessary to achieve that temperature. And typically we will tell the computer, don't go above 50 watts, which is usually the maximum power of these systems. So what you notice when we do ablations, let's say on the left side of the heart, is that oftentimes the power will be 50 watts. It'll reach the maximum power, and the temperature may only be 45 degrees, which is still very hot, of course, but is not the 60 or 70 that you may have asked the computer to do. And the reason it doesn't reach that temperature is because the blood is coursing over the tip of the catheter, cooling the tip of the catheter continuously. And so that's basically the highest temperature that the system can generate in the setting of the full cardiac output crossing past that catheter tip. But typically, if you're at 50 watts and you have a temperature of 45 degrees Celsius, you will make a adequate lesion if you're in the right location to successfully ablate something. When you're in the coronary sinus, however, the blood flow is very sluggish. There's not very much blood flow in the coronary sinus. So if I were to use a standard radiofrequency catheter in there, then basically what would happen is if I set it, let's say, at 60 degrees and 50 watts, it would hit 60 degrees at almost no temperature, maybe 5 watts or 10 watts, because without all that blood going across the tip of the catheter, the catheter tip will reach high temperature very easily because it's generally not as cool in there because there's not as much blood flow. The problem is that if we are at 60 degrees and 5 watts, we are not going to make an adequate lesion. You need both a combination of power and temperature. And so as a result, the two approaches to ablate within the coronary sinus are either to use an irrigated catheter in which you cool the tip of the catheter with saline through the head of the catheter. Those of you who've worked with both me and Barry, but Barry to a larger degree, see that he often uses an irrigated catheter. And then you set the power. So in a irrigated catheter, it's a power controlled catheter. And you tell the computer, I want to go to 20 watts. And by cooling the tip of the catheter, you can achieve better power delivery. And in fact, many studies have demonstrated, experimental studies, that you make much deeper lesions with that. So when you're ablating in the coronary sinus, one option would be to use an irrigated catheter in order to deliver greater power there. And an alternative would be to cryoablate there, because cryoablation does not depend upon heating. It's actually freezing, of course. And so you can cryoablate there without any concern in regards to the temperature of the blood going across it. Now, either would work in that circumstance potentially, but the chances of perforating the coronary sinus or coronary vein is far greater when you're using irrigation in that area. So one would either use a very low power ablation in that area or cryoablation, because we think that the likelihood of perforating somebody would be less with either a very low power application or more likely lower still with cryoablation. So in this case, I chose to do cryoablation, and it appears as if the ablation was successful because we see that the pathway has stopped conducting. Now, the disadvantage of cryo, as we've discussed before, is that it is not as effective long-term. And the other problem with cryo is that the catheter is a very stiff catheter, and especially in children, it can be challenging to get the cryo catheter to go into the coronary sinus very far in order to deliver the cryo energy. So whenever we see a pathway that requires us to put a cryo catheter into the coronary sinus, it can be very challenging and unpleasant. Struggling to get this very stiff catheter, and sometimes in the process of trying to stuff this catheter into the coronary sinus, you can inadvertently bang into the His-Purkinje system and cause transient heart block. So it's not something we would like to have to do, but we do sometimes have to do that. So anyway, in this case, it appears as if we were able to successfully ablate the pathway from within the coronary sinus using cryoenergy. It would not normally be our first try, but probably in this case, either we went to the left side and failed, or we thought it was so close to the mouth of the coronary sinus, yet still inside the coronary sinus, that we felt it was maybe approachable from the right side, which in this case it appears to have been. So any questions about that? No. All right, well, I see we're already at 25 of the hour, so I think we'll stop here. Hope those were interesting cases, and I'll see you back next week. Thanks for joining, everybody.
Thank you.
you.
Thanks a lot.